Okay, thank you very much for attending today. I sincerely hope that you leave here today with some tools that you can take back with you into your own practice. Even if you are not working that much with nursing homes or facilities of the like, or even patients who are utilizing them, but if you have other areas of your work where you are having communications with different organizations who are helping with your patients, I think that there should be something that you can take away today. So think about everything that I'm saying in terms of your own experience, and make sure that you try to translate what we're talking about into your own experience. You know, something that came up a little while ago was about decline when you enter the prison hospital. There is supposed to be no decline in your health as a direct result of your institutionalization in a nursing home environment. It's easy to say, but that's actually the case. It shouldn't be directly related to your care there. And we'll talk a little bit about that today and how to ensure that that is happening. So my areas of expertise are in program planning and health communication and hospital administration. I have been, as Tony said, working at UTMB with helping to identify areas that we can reduce readmissions from nursing homes after people are discharged from our hospital. We need to prevent readmission for the sake of not only the patient and the patient's family, but the nursing home themselves. It's a really difficult situation for a nursing home, the hospital, and the financial well-being of all of those involved, from the patient to the hospital. The learning objectives today are to discuss the standard staffing structure of nursing homes in case you don't actually know what the different kinds of people who are employed there are called. I know a lot of times people just say nurse, but they might be referring to a lot of different people. Additionally, we're going to try to understand how to navigate the statewide search for nursing homes and long-term care facilities. This will be brief. I'm just going to show you where you can go to find information on nursing homes if you don't know where to look, or if your patients don't know where to look. Another thing we'll talk about is the challenges faced by health providers when you're caring for nursing home residents or their family members. And this could be inside or outside of the nursing home. There are lots of challenges, but we'll focus particularly on one pilot idea and should try to tackle some of those challenges. Briefly, let's do a short history lesson, and this is going to be relevant. You'll see in a little bit why we need to talk about the early history and what has happened to the nursing home over the decades in the United States. In the colonial era, the family typically provided assistance for older people. Towns and villages would make informal arrangements for people who didn't have family or money to care for them. And if you remove the colonial era tag from this, I think in some cases it sounds a lot like today in some of our communities because of lots of different factors like cultural factors, financial factors, and the perceptions of nursing home care. Social networks still care for elder people, but there were institutions from very beginning. In large cities, almshouses were typically public institutions established to help maintain life for the poor, sick, and needy. These were charitable housing communities. They were targeted at the poor to keep them in a local community if they had no ability to work and possibly pay for care themselves or a place to live. Or sometimes these were focused on people who were in particular professions or the widows of those people, like veterans or things like that. But over time, institutional care evolved a little bit more beyond the almshouse. The almshouse was kind of a the first place anybody would go. But as Patrice said earlier, it seems like it was a good idea to start putting people who are older in similar situations. You have access issues, you have similar healthcare issues, and so if you could focus the residents and together, then the people who are caring for them can have a shared skill set that can provide optimal care. This picture is from Norway. It says Old People's Home. I was in Norway. This isn't my picture, but I was there once, and that's what they still say on the outside of their homes for the aged. So you'll hear a few different phrases historically: private homes, homes for the aged, boarding homes. Boarding homes were generally shared responsibility homes. So there might be a landlord, but a lot of different people lived there, and they shared responsibilities, keeping things clean, and but they could do it with a very, very little amount of money. As the shift towards private options began, there were the same number of people in almshouses as there were in homes for the aged. But very, very quickly, the dramatic shift as people saw the benefits of this happened. So in the early 1900s, there were over 1,000 homes for the aged, caring for almost 70,000 people. There were new laws after that to help old and needy. The old age assistance law specifically allowed old people to pay for care and lodging in boarding homes. It helped a little bit. And then in 1935, Social Security was signed into law by President Roosevelt, and Social Security provided some cash benefits to older people. It didn't pay benefits to people in public facilities, so this made people think, okay, I need to go to outside of an almshouse type situation, and if I can, go to an for-profit home, because I'll have some money coming in. This also produced an aggressive expansion by private industry, because after that, not only were Social Security benefits allowed to be used for some payment of boarding, Medicare and Medicaid was beginning to cover nursing home care in the 60s. When I say an aggressive expansion, it was by private industry. It's important to note that that doesn't necessarily mean that the expansion was in private expert industry. So there were problems, and there were at least 20 very, very serious studies that led to an investigation of the government on nursing home care. And this is kind of where the perception of nursing home care today has really, it's been very hard to overcome this perception. So the Institute of Medicine report came out in the 80s, mid-80s, I think it was 1986. This was probably about 20 years after nursing home care was covered by Medicare and Medicaid. On the very second page of this report, think back to the 80s if you can, and where you were and where your family was at that time, and you probably still know most of the people who you were with at that time, so we all still have this perception. The second page said that there were people who were receiving very inadequate, sometimes shockingly deficient care, and that in some cases they were also likely to have their rights ignored or violated, and may be even subject to abuse. So this was front page news type stuff. Then there was a statement about quality of life and sort of a subtle non-abuse situation. This was also on the second page of the report. There's poor quality of life in many nursing homes. Residents are often treated with disrespect. They are frequently denied any choices of food, of roommates, of the time they rise and go to sleep, of their activities, of the clothes they wear, and of when and where they may visit with family and friends. These problems may seem at first to be less urgent than outright neglect, but when considered in the context of a permanent and final living situation, they are equally unacceptable. I was thinking as I was reading that earlier that it sounded a little like prison, and told Patrice that there was a thread. We have a thread in our topics today. So that came out in 1986, about 25 years ago, shaped our perceptions of nursing homes to this day, and I'd like to talk more about how we can, how the field has overcome a lot of that. New regulations were put in place almost immediately. In 1987, the overall goal of new regulations was to provide the highest practicable physical, mental, and psychosocial well-being for each resident. That is what the government decided was the best goal to have, and that stands today. And I think that over time, you know, you're not going to have change right away. And so that came out in 1985, but change is incremental. It takes a long time. So I imagine for at least a decade, there were still people feeling like they were having those same experiences. Nursing homes who were not adequate were more likely to be closed. And now, to present day, you have to report all of your inspections and complaints and to be readily accessible by citizens, at least in Texas. So what I wanted to figure out from the group is how do you know about nursing homes in your area? Is it usually, raise your hand if it's because these are the ones we always send to. Word of mouth. Word of mouth. Google. Yeah, there is a lot of information on Google, and there's also a lot of information tailored to your particular area. This is relevant to all the groups we're talking to today and your counties that you're living in.
You can get actually some state ratings on some of these things.
Mm-hmm. That's what we're going to look at right now, actually. One of the things that you can do is identify if your county is associated with an ADRC, which is a resource center for aging and disability. This is the homepage of the one called East Texas, but it actually doesn't correlate with our areas in the GEC. But there are these targeted resource centers, and they have links on them for help. Every single one is a .org and usually has a little bit of a different feel to it, and you're supposed to be able to find resources with them. So if you want to figure out which one that you are associated with, the first link up here, pascenter.org, can tell you exactly which ADRC is associated with your county. The one that I think would be most relevant to our areas is the Gulf Coast ADRC. It's called, you can reach it at careconnection.org. I'm sorry I didn't have that up there, but we can update the slides with careconnection.org. They serve the counties of Austin, Brazoria, Chambers, Colorado, Fort Bend, Galveston, Harris, Liberty, Montgomery, Walker, Waller, and Wharton. And the purpose of the ADRC is to provide what they say their four core roles are: navigation, care coordination, wraparound support, and education and training. I think that I was go into all of those, but you can easily find out what those things mean when you go to each ADRC website. It's probably a little bit different depending on their staffing, but those are great resources. If you want to find out about very specifically nursing homes and the ratings that we just discussed, all of those ADRCs will have a link. That link is going to send you to the Texas Department of Aging and Disability Services. That is the second link on this page. They call it DADS. The DADS website, I would go to it, but instead I chose screenshots. Hopefully you can read them. If you can't, on your pages, you'll be able to see this online. I put a little circle where you would be clicking to go through what we're talking about right now. This is the homepage of the Texas Department of Aging and Disability Services. I think that one of the very first things, if you want to look for ratings, you want to tell somebody to look at ratings, or if you're interested in complaints or anything fishy going on, or you're looking for confirmation about something, go to Help for Texans. Help for Texans is great for healthcare practitioners, but also their families. And when you click on Help for Texans, you'll be taken to a page that has a lot of different links. It's not the most user-friendly website when it comes to being able to sift through what's on each page very quickly, but because they have a lot of information. The minimum being organized for Texans versus doing business with dads is really great. So you would want to look for instance, nursing homes in my area. I want to know what the latest is. How many are there? I heard one closed. I don't know if that's true or not. You can click on freestanding nursing homes and check it out. You could be directed to a page where it asks you for county, zip code, area code, or city. So if you're just really not sure, or if you're in a very large county, or you're in a county with a lot of small cities and you don't want to go that specific, but you know that if I search by county, there might just be a couple. You could search whichever way you think would be best based on the size of your population. So I chose city for this example, and I went ahead and chose Waco because they had a lot of options for us to look at. So I type in Waco, and they ask me if I want to compare facilities that accept Medicaid and Medicare, or I want to do facilities that do not accept Medicaid and Medicare. And this is definitely going to be relevant if you're working with someone who has choices about where they want to be discharged. And really, everybody has choices. If you are starting to feel like there are no choices, that is definitely when you want to send someone, or you yourself go to the ARDCs, because one of their services is to help make sure that it's family, that the family is very involved, and they work to mobilize family or social support to make sure that there are choices in what to do if someone needs to access a nursing home. So I chose ones that accept Medicaid and Medicare, and you'll be brought to another screen where you'll be able to scroll down and see all of the different nursing homes in Waco. If you're familiar with Consumer Reports, the rating system here is very similar. The red being the best, the half red being, pretty good. Least favorable is a solid black circle. And so you can look quickly and compare the different ones. So here people have similar scores. They are in competition with each other, even if they're accepting Medicaid and Medicare, not-for-profit. And you can see every single one, their phone number, and where they're located. So if you wanted to drill down a little bit further, I chose one called Royal Manor. It had a mid score. Every time you want to see what the average score is for the state, you'll find it when you click on any facility. So for freestanding nursing homes that accept Medicaid and Medicare, the state average was 63, I believe. So half of them in Waco looked like they were above the state average, half looked like they were below. So if I want to see a little more about Royal Manor, which looks like it has an inspection and an inspection score of about 50%. And these are also investigation scores. So this is investigation on the left and inspection on the right. I'll go a little further. And this website can tell me where it is on the map, who owns Royal Manor, and how that ownership breaks down. So you can look at the controlling structure and figure out, is this a chain? Is this for profit? They have their residents' rights and responsibilities right at the top, so you can get a PDF of residents' rights and responsibilities before you even make a phone call. You'll see the total bed count with whether or not they accept Medicaid and Medicare, and which county that this is in. So this is in McLennan County. As you scroll down, you can see their overall rating with the state average. These are tough to read, but that's what this is. If they've had substantiated complaints that have been investigated and validated by inspectors. Now, that doesn't mean that they haven't had a lot of complaints. If you see just one, what this really means is substantiated for their inspections. All the inspection criteria are below as we'll scroll through. This tells you about their investigations and when their investigations happened, and comparisons to the state of Texas with regard to the health regulations and life safety regulations. So here you can see, and in most cases, yes?
So it tells you how many beds they have. Is there anywhere you can get the information about how many beds are full so you know before you even make the phone call?
I believe that you can find out how many beds are full. They are supposed to report a bed status, and Norma, you might be able to tell me this. The bed status is supposed to come every single month from every facility in the whole state. And so you might not get, if everyone turned theirs in 28 days ago, it might not be current. But on the DAD's website, you can find out if they're full or not. It's not in the ratings. Okay. So it's going to be in another area of the website. But yes, definitely. Now, in most cases, these ratings, or the dings on somebody's report, or it's like when you're looking at restaurant dings. They're what some people might consider to be minor, some people might consider them to be major. And so what the website does is show us the severity of the deficiency. Is this actually going to lead to harm to someone or not? Is this very likely to lead to harming a person in their care or not? And in most cases, you'll see it's minimal harm. That generally, this could have been an ADA thing. Maybe they attached hand sanitizers to the wall, not thinking about that as soon as something sticks to the wall, it's now belongs in ADA's category. They may have just put them up there. That's why we were laughing at UTMB when we did an analysis of hand sanitizer placement, but it was really serious because all of a sudden that you're in another umbrella of I'm sorry, there's something fly up here. So anyway, you can scroll down, you'll see the facility didn't make sure nurse aides show they have the skills to be able to care for residents. Doesn't mean they don't have the skills. It means that they may not have had a demonstration exercise that they could document. These things are expected to be corrected within a month, and in all cases that I've looked at, you'll be able to see the date when it was corrected. But I thought I would show you one that was, supposedly, I guess this would be the lowest one in Waco. This is, I don't remember what the name was, but this is not Royal Manor. It's all the way at the bottom of the list. And you can see there are some 3s highlighted. Means there could be actual harm done. One of them was that the facility didn't make sure residents are being carefully watched with regard to their drugs. And they explain 5 different things that are having negative medical effects. And they are expected to correct this, and it shows they did correct this by a month later. They probably corrected it much sooner than that. They weren't necessarily stopping or changing drugs that had unwanted effects. And then their actual harm score is at 3. What I would recommend is if you see something like this and you have a family member or one of your patients' family says, oh, I looked and they had 3s, looking for the pattern. look for the pattern of the nursing home and what you see in the past. You can look at these every single time they have an inspection. If every other inspection they're at a 3 for not paying attention to unwanted side effects, that might be something you really want to consider. So you can help make sure that your patients and their families are feeling, comfortable about their care if you look at overall patterns. So you can research them, but not everybody knows exactly how the nursing homes work. Understanding how they work is a big part of the communication battle in any organizational setup. Helping them understand how you work is also a big part of any communication barriers. So that's another piece, and we'll talk a little bit about that. The consumer has some expectations of nursing home cares. This isn't necessarily related to their fears. This is just their expectations. They want medical care. They want it to be like when they're in the hospital, as good as their hospital or their usual doctor is providing. They want their individual preferences respected. They want some privacy and good social interaction with people who feel like them. It's really what people expect in most situations. This is the traditional nursing home structure. It's hierarchical. The nursing home owner at the top making a lot of decisions about how care goes. This is sort of a chain of command. All chains of command are going to be published in nursing home manuals. You should be able to obtain these very easily and would provide instructions on how you address questions that you have if you need to find out something about somebody's care. The chain of command really begins with the immediate caregiver, in my opinion, when you have something you want to talk about with regard to a patient. These are typically nurse aides, sometimes also medication aides. When I say nurse aide, I'm talking about CNA. The CNA is responsible for daily care and helping with activities of daily living. They are a very important person for the patient and the family member to have a relationship with, and they know a lot about this patient and their families. Sometimes the med aide does similar duties. They will prepare and administer medications. If they need to do vital signs in order to give a medication, they can do that. There are not always med aides. And the overlap may be a little bit confusing. So if you're having trouble getting questions answered about something, the next person in the chain of command would be your licensed practical nurse, who may be less hands-on specifically with that patient than the CNA, but will know about the patient and will know how to help you ask your questions or get your questions answered. The LPN gives medications and treatments. They do catheters. They do things that CNAs are not permitted to do based on licensure status as well. And they spend a great deal of time with the patients on the floors. And then there's a registered nurse who's responsible for overseeing the CNAs and the LPNs. The registered nurse would start and stop IVs. They set IV drip rates, things that are very technical in nature with regard to the medical care. And if you have questions, calling the administrator or calling the person who's owning the nursing home is not the best way to get your answers. You really want to start with who's spending the most time with that resident. And if they're not allowed to talk to you about it, they'll make sure that you can be in touch with someone who does. So this traditional structure, there are perceptions about this. Perceptions that people don't want to go. They worry about inadequate and unsafe care. They worry about high turnover rates that we see in nursing home frontline staff. They worry that people will have less staff because of turnover and clients will be treated and rushed manner. And then there's continuity care that's always a concern when you have high turnover in frontline staff. We have similar issues, at least in the hospital system. We work in an academic health science center here at UTMB, and we have rotations constantly. Our medical providers are rotating in and out on typically a monthly basis, sometimes even weekly. And so on the flip side, they have similar difficulties with our setups and our chains of command. So I'm going to show you a little video now about what is called a culture change nursing home that you can think about. It may make you think about your perceptions or your current perceptions of nursing home care. There are a lot of achievements here in this video versus what you might expect a nursing home to be like. Because they're focusing mostly on people with dementia here, this is not going to be the same for nursing homes that have a wide mix, but I know that dementia is going to be an issue in a lot of nursing home situations. One thing that I can note here is something they talked about, the inconvenience for the staff, the inconvenience for the schedule of the day when you have your patients leading, in a way, some of the care that's happening. And one time I visited the UTMB acute care unit for the elderly and talked to them about just the day-to-day goings-on, and somebody said to me, the layout of our floor plan is not provider-friendly, it's patient-friendly. And I encourage you to look a little bit more about how some newer built nursing homes or older nursing homes are rearranging things to be a little more person-centered and a little meet in the middle somewhat with provider-friendly versus patient-friendly. And you think about what this costs and what this means, and just think a little bit in your head about what you've seen already and what you would like to see if you were going to be visiting a local nursing home. Or a structure like the one we just saw, the nursing home industry is calling a culture change nursing home, where the residents again sort of dictate the day and the treatment. A lot of it is based on understanding their patterns. Well, this is a challenge when you have turnover in your staff, and but if you were watching the video, you see how hard that job was of the aide who was with the patients. She was keeping her cool and continuing to talk in the same kind of voice and staying on point and staying with her training, and but it was a very, very, very difficult job. And all the staff in the nursing home facility are faced with difficulties, with a lot of people needing your help right then and there. So achieving something like this is definitely something that would be very difficult if you're starting from a traditional nursing home structure. I'm highlighting today a pilot program that happened at UTMB actually a long time ago. The reason I'm highlighting it is because you can translate this into within organization and between organization pilots. So even though some of the feedback that I'm going to show you that happened here is older, the case is very relevant. This is about achieving continuity of care, and you noticed that, and we talked about it a little bit, the turnover of staff and rotations of medical staff in teaching institutions can be really difficult. And there are challenges to communication. And this doesn't do anybody any good. It's not helping your patients, and it's not necessarily helping your staff. So one thing that was that our nursing staff at UTMB and the ER started was the Nursing Home Liaison program. this was when they identified that they needed a system of improving transition and communication between our ER and long-term care facilities. And they identified a primary facilitator of communication between the hospital and nursing homes, and this was a nurse staffed in the emergency room. There were challenges between both organizations. The turnover, as we've discussed, cultures of treatment are different. An ER is very different from a long-term care facility. And there are ways to make changes that don't have to be extremely dramatic, but there are a few things that you have to do. And one of the very first things you have to do is ask why. And you ask why until you get to the root cause of a problem. And this is difficult to do because it will involve your ego, it will involve other people's egos, it also involves some time. So first thing that they did was asked the local nursing homes, what are the problems with or your communication with the emergency room? There was a common theme of what's called faulty communication. Common themes were difficulty reading discharge orders, no phone numbers to call for clarification, calls to main hospital numbers were fruitless, care members didn't send, quote, appropriate papers, nurses didn't give, quote, thorough reports, they felt like they weren't getting updates on the patient's progress in the hospital. Now, these, I'm not being very specific with appropriate and thorough because these are specific to your situation, so try to think about your actual situation. What's appropriate to you, what would be thorough to you is important. More problems, late discharge, change of medications at the last minute, difficulties from nursing home staff making clinic follow-up appointments, not having documentation after specialty clinic visits. These to me look like problems with lack of auto processes. And again, you don't necessarily know until you ask. If you ask the organization you're working with, like the nursing homes, you'll find out. But you also may want to test out some of these because sometimes it's just a matter of education. More problems, discharge report. We didn't used to not have discharge report from the ER at that time. The nursing homes felt like the ER was quick to report for abuse or neglect without adequate information. That's very important. And also feeling like the ER discharged patients at, quote, unholy hours. Is anybody in here work in the ER? I can see some of you. It's probably not as much of a problem these days because I think people have thought more and more about this hours of discharge, but it's not really good for anybody. Other local Galveston complaints were simple things that could be fixed, problems with fax transmittals, not feeling like they had a phone number, frustrating experiences when calling the main hospital. When you hear complaints like that, you can try them out. It may be that it was very easy to call the main hospital from your perspective, but from theirs, try it with a different point of view. So think about someone else, starting where the other person is. The hospital had also their thoughts, so don't feel like you're the only ones taking a beating. The nursing staff in the ER complained that calling nursing homes, they didn't feel like people were answering the telephone or the person they talked to didn't have information about the patient. They felt like they were being put on hold for indefinite periods. The care managers felt like there weren't timely answers about inquiries, that nursing homes didn't pick up patients who were ready for discharge. But I saw that and thought, okay, well, the pickup and the discharge, there may be a time of day issue there, and the hospital was complaining that people weren't being picked up. The nursing home was saying that hours were unholy. that was definitely a clue. You can look for overlapping complaints that can be resolved in a mutually agreeable way, hopefully. So what they did was establish a nursing home liaison who attended weekly interdisciplinary rehab meetings about patients, communicated themselves with specialty clinics, and facilitated appointments for urgent referrals. It's easy to say this person needs a follow-up appointment, and everybody is pressed for time. It is faster for someone who works within a hospital system to help make a follow-up appointment for an urgent referral than it is for someone who isn't in the system to make those appointments. So that was something that was mutually considered and agreed on. Phone calls started to be triaged, and there were a lot of other functions that a nursing home liaison could take on, but it would be modified for your system and your reality. And you should ask your staff, what do you need? What do you usually get? These are, what do you usually give to them? And what are your concerns? So they made some solutions in addition to the nursing home liaison that were simple solutions. These are no-cost situations. These are place the nursing home numbers in the computer. That's simple, but if it's not there, it's causing problems, and sometimes you just don't know who to ask. But you have to keep asking until you get to that bottom answer. Have the nursing home charge nurse call the ER charge nurse and inform that the patient is coming. This is also, fairly simple, but it could slip through the cracks if you're really busy at a nursing home and a whole bunch of things are going on and you realize that it's been a little too long since the patient left. But it could be really helpful for everybody if the people are speaking ahead of time. Putting the geriatric CNS phone number in the computer so the ER staff can call as needed. Just making sure that phone numbers were available. Having a transfer form was something that they did. There wasn't a transfer form at this time. This would give a specific reason for the ER visit. You could develop these kinds of forms with another group if you're transferring within your organization or between organizations. What works best for you? This is medication list, DNR status, advanced directives, other needed information. They also gave local nursing homes a specific ER phone number to call to report to, or call the ER to get information. It's scary to hand out a phone number to the ER. You don't necessarily, people would probably be worried that it was going to be abused. So I don't know who's going to be abusing the ER phone number, and if that happens, maybe you could take a look at changing it. But generally, this can save a lot of people frustration and hopefully time if calling the main 1-800-UTMB is not the best way to get to the ER when you just have one bit of information that needs to get across. So the transfer form included information that was completed in 2 phases prior to the need for emergency service at the time of the emergency, so that there was information already ready, loaded in a form. So at the time of an emergency, they only had to put in the other half of the information. So a medication list could be updated regularly on this form that you keep with a patient who's in your nursing home. And the DNR status, these things can be updated monthly, then printed out. The other half could be used at the time of an emergency. It's just a swift way to aid communication. They learned some lessons though, and so when you pilot a project, this is why you want to pilot and start something small, because compliance with completing the form was inconsistent if there were frequent changes with nursing home directors of nursing. And also training nursing home staff was needed due to the high turnover rate. And I think that continuing to teach each other about your processes can definitely help with communication. they needed a log of transfers to the ER to document compliance. There were things that they hadn't thought about ahead of time. So, like I said, some of these things definitely cost time. Identifying someone who is going to help with communication between a nursing home and a hospital situation or a clinic situation is not going to be simple. But again, if you start to ask why and you start to ask for feedback, you may be able to make some of the smaller changes right away without identifying extra time needed for extra staff. And I chose this because I think that it can be something to think about, or a pilot to reread when you are done with this. Think about how you can make some communication changes if you're working with long-term care facilities or vice versa. You don't want to be replacing people with robots. This is a people field, but you can make small changes in your innovations. I was hoping that we might have a chance, but I don't know if we have any time, nope, to hear about your interventions, but that would be a wrap.
Thank you very much.
Thank you.